Thank you, Dr. Chu, and thanks to all of our speakers. And we have some time for questions now. However, due to our scientific hyperexuberance, we're a bit short on time. We only have about 15 minutes, so please make your questions brief and ideally your answers brief as well. That's really brief. Dr. Backey.
In an effort to be focused, thank you to the panel. Wonderful presentations. I came away from the clinical efficacy information reinforced with the notion that there's a lot of things that work, they just don't work well. Effect sizes are typically mild, 1 point on a 10-point scale. And I think one of the things I didn't hear called out was the notion that these RCTs are usually based upon highly homogenized clinical patient populations. And so I put it to at least a couple of the speakers here. Are you calling for the need for more pragmatic trials done in real-world patient populations that are more reflective of who we care for, noting that the vast majority of clinical trials that we screen 10 people for every one that actually gets enrolled? And maybe that's, if you need somebody called out, I think the first speaker, Mark was focusing on that issue.
So it's a good question. I think there needs to be multiple different designs that can be used. So one other area that I've had interest in is N of 1 randomized trials. And also there's hybrid designs now where you can have N of 1 randomized trials or small group studies. And so then you can start looking at some of these subgroups of people. So I think the scientific methodology of getting outside of what we've been doing is also a really important question. So that things can be done in an efficient way, time efficient, and then also money efficient.
Francesca, yes.
Is it right? Okay. I think my question is also for you, Mark. Did you come across any trials, either randomized control trials or systematic reviews for education? So especially in your comments, you talked about the importance of training and what you tell your residents.
There's been quite a bit of work done with both TMD and also other pain conditions with everything from simple information to more complex, and it falls in the area of behavioral medicine, and I'm not an expert in those areas. I don't know, Roger and other people.
I meant medical education and dental education for providers.
Oh, for providers?
Yeah.
Oh. I'm not aware of anything that's looked at training, but we have a strong feeling that there's a real need because the physicians don't get the training, and then dentists don't think it falls in their area, and then the patients are stuck in the middle. So that's what we've seen for years.
Yeah, Mark, I'm certainly sympathetic to the results of all of the systematic reviews that say that low quality or not sufficient evidence. Is there any way to, in the sort of the gap between this and when we do have quality RCTs, to exploit maybe the electronic medical records using ICD-10 codes or something to look at long-term outcomes, retreatment needs, persistent diagnoses over time, to see anything about informing our approach to care and even prevalence data?
I think it's correct that that you can use other designs, and so we're talking just about RCTs here and the systematic reviews of them, but of course there's cohort studies and others that can be used to look at prognosis and other other questions that can still be maybe better in some cases depending upon the kind of question. So it's it's an important point. Just for this reason, I'm just at the top of the pyramid specifically, but there's still other designs can still be valuable depending upon what the scientific question is. I mean, there's work being done, and I don't. Maybe I'm coming across a little bit too negative, but I mean, there's definitely people that get better with therapies, and there are definitely very strong randomized controlled trials with TMD. They're almost always ones that have been NIH funded because they've been vetted and they're carefully. And so there's people in the room here that run those. So it's just the majority are weaker. Yeah.
Can I share your microphone? Because, Mark, I just wanted to, lest people think that the trials are so lousy, we should stop funding them. I just want to pick up on the point you just made.
I just had a feeling you were going to say this, Gary.
And this is a plug for NIH. People doing NIH-funded clinical trials, there is no way that they can not collect and report data on adverse events. There is no way they can make data invisible with the requirement to register with clinicaltrials.gov and to upload the data. And those are, let me call it, the institutional requirements. The study sections are going to kill any applicant who doesn't mention impact and therefore take into account relevant quality of life and other outcomes that are not just perhaps some of the ones that have led to poorer quality trials. So, I mean, NIH is a great friend in creating great quality trials. They're not easy to get funded for, but I would urge us all to try to live up to those standards.
Well, yeah, I mean, the answer is that out of those 750 randomized controlled trials, the ones that are NIH funded that are of high quality are, it's a handful. Right. But that's the thing is that when I'm talking about stopping, what I'm talking about is that we would have standards that would be as high as the RCTs in NIH funded. But also, I think there's an opportunity by just listening today, which has been a great session, that I mean, there's new emerging ways to better stratify and better characterize patients, and we need to take advantage of that. And I'm really certain of that. I have a strong feeling about that.
Yes. So one of the things I wanted to make everyone aware of, as I mentioned, the HEAL initiative, I did not go into detail about any of the current funding opportunity announcements that are offered through HEAL. One is an opportunity calling for pragmatic clinical trials across all pain conditions. Another is a clinical trial network for comparative effectiveness. And another is a clinical trial network providing the infrastructure for testing assets across any pain condition that comes in. So I just want to make everyone aware that it's an exciting time and the opportunity is there.
It's a question for Alex. I think the potential role of the endogenous opioid system using PET studies was really exciting. Folks like David Yarnetsky and others have been looking at measures such as conditioned pain modulation as a matrix or an index of endogenous opioid or receptor modulation. In your studies, or are you aware of other studies which have looked at conditioned pain modulation in TMD patients and how it affects their overall pain picture?
The interesting thing, the most results that we see with chronic pain patients, the neuropathic pain, migraine, episodic and chronic, and TMD, is not much during the baseline, so comparing them with health controls. Most of the changes that we see in opioid system is when they are faced with a particular stimulation. So it's the reaction to the stimulus or a function is that you see this limbic activation that's quite stronger, much stronger than the health controls. So it's very important not only to look at patients at the baseline, but also have some kind of challenge with stimulation to look. And now we are not looking at more opioid system. We look more opioid system because it's the target of opioids. But we also now able to do with, we just got approved from the RB for kappa opioid, and there is already some hope to use for delta opioid too. Why is that important? Because that can help us to better understand our own system, to then that have be more effective in medication that target those receptors in the brain, especially opioid, and perhaps with less of the side effects that we see with more opioid.
This is Mark. I just want to make a comment about CPM. So we've been working on a project for the last 4 years of having a chairside measure of conditioned pain modulation. It just consists of having a somatic algometer and then having your hand in ice cold water and working on the reliability of that. And the idea is that could be done in 2 or 3 minutes. And the working hypothesis is that, for example, athletes, et cetera, they have really very efficient CPM. And so that's some of the underlying basis of why physical activity can actually help people with any kind of pain condition, especially musculoskeletal pain. So I think measurement of it is a good idea. I think it may support some of the other self-care and other physical activity things that have been shown in some RCTs to be valuable across musculoskeletal pain conditions.
So I have a question for Dr. Chu. So you just showed very exciting results. Look, the tissue engineering approach for the joints and the knee joints or the hip joints. So my question here is, we learned a lot from those efforts. So how gonna basically, when we translate it to the TMJ, is it necessary to really consider their difference, the anatomic difference, especially more look at the biological difference. So we know from the developmental biology, so the joints, TMJ, it's not exactly as we developed the lumbar and the knee joints. And the cell type and all the things is quite different. So is there need kind of further, specific research in terms of tissue engineering specific on the TMJ?
Yes, I think that listening in today, there are a variety of things with the TMJ joint that are the intersection of many more disciplines than when we're looking at worn out hip or worn out knee. Much of our issues are mechanical. There are biological components, but when we remove the damaged joint tissues, typically we have resolved a lot of the biological issue in knee or hip osteoarthritis. Now, when there's a large inflammatory component and also different cell types, I actually think that this particular joint may benefit more from biological resurfacing, biological intervention. Less so from metal and plastics that need a substantial source of bone fixation that doesn't really exist in the small area of TMJ, especially in the cup area, which abuts really the dural space. So I think there's tremendous potential for cartilage and joint tissue engineering in this space. Thank you for the question.
Thank you.
Yeah, just to comment to the committee on education. For several years, I've been interested in how to penetrate curriculum committees and the curriculum of medical and dental education. I was former Associate Dean for Academic Affairs at UNC for several years. And on the different committees I've served on and following the review of the IOM report, I was struck by a number of things. One, the medical students receive 7 or 9 contact hours related to pain. Dental students, about 17. Veterinarians, 30, 35. And I've become more and more convinced, having been an associate dean and trying to steer a curriculum committee, how difficult that is to find hours. And I firmly believe that, the various accrediting agencies with the AMA, ADA will not be sufficient in developing competency standards for our students. In my view, the best way to approach this is through the Department of Education, which will ask our accrediting agencies to come forward with the appropriate standards and educations in the area of pain, including TMD. So when I'm on panels like this, I usually request that the committee begin to look deeper into a relationship with the Department of Education, which will drive curriculum, drive standards, and in the end, will drive faculty and research opportunities in this area. So I see an education-based initiative that could ultimately drive research initiatives, but it's not going to happen from the ground up, unfortunately. I think it needs to come from top down.
Okay, thank you very much, our panel 4 speakers. And we'll go back to Drs. Mackey and Bond for our public comment section.